Hello, my name is Tom Stinchcombe. I work at Duke Cancer Institute in Durham, North Carolina. I'm a thoracic oncologist who specializes in clinical care as well as clinical trials for patients with thoracic malignancies. For patients with limited stage small cell lung cancer, the combination of chemotherapy and radiation therapy has curative potential. So when we see a small cell patient, we make sure that we do due diligence in the staging. We generally have used a PET scan to stage for extrathoracic metastases. And we get a brain MRI to make sure that there's not occult brain metastasis. Then we talk to our radiation oncologist and make sure that the disease can be contained within a reasonable radiation port. From the medical oncology side, the standard is cisplatin and etoposide. That's what's been used in our trials. I think most of the time people are getting more and more comfortable with substituting carboplatin for cisplatin just because some patients are not candidates for cisplatin due to renal insufficiency, age, or in terms of the ability to tolerate it, hearing loss, or they might have a congestive heart failure and the IV fluids that are required for cisplatin are difficult to tolerate. So for the medical oncology side, it's fairly simple, but I think for our radiation oncology colleagues and the patient, it's not, particularly when we look at the radiation schedule. And there's been a series of trials. One was an older trial that compared twice daily radiation therapy to 45 gray, to once daily radiation therapy to 45 gray, that revealed a improvement in overall survival, and importantly, an improvement in disease control within the chest. And so the twice daily radiation therapy really prevented what we call interthoracic recurrences, and this led to better survival. And I think that this established the twice daily as sort of the standard of care. But many times when we do these trials, then the part of implementing them into routine clinical care can be challenging. And what we found is there are logistical barriers to taking the twice daily radiation therapy. Some patients find it very inconvenient to be around the oncology center for twice a day or the whole day, because you need one fraction in the morning, one at night, not at night, late afternoon, excuse me. And so I think those are some of the issues that we found that are barriers to the implementation of this. I've had other patients who maybe travel from far away say like, well, wait a minute, I can get this done in 3 weeks instead of 5 weeks. I might as well do the 3 weeks. And so I think it just really depends on the patient. And I think a lot of it depends on how it's discussed with the patient. And I think the twice daily has been sort of the preferred, but not mandated is the way I would describe it at this point. And there was a more recent trial called the Convert trial from Europe that attempted to really look at this question. And they compared the twice daily to a higher dose of the once daily radiation therapy, more in lines with our current standard of care. And they found similar outcomes. There was a slightly longer survival in the twice daily, but it did not reach statistical significance. I think this trial did tell us some important information, though, in terms of the modern radiation oncology techniques. The toxicity between the two arms was roughly similar. You know, we saw similar rates of esophagitis and pneumonitis and other aspects. And so the twice daily wasn't really associated with incremental or additional toxicity. So when we see a patient, I think we kind of have to have a discussion about the once daily and the twice daily radiation therapy. I feel comfortable using both. I tend to use I think some of the patients who live closer to the center will kind of like the twice daily in some ways because it just is a little bit more convenient. Well, sometimes the once daily is if you have to drive an hour up there, and you can get it done in the morning, drive an hour back. The once daily is helpful. Now the NCI, National Clinical Trials Network, has done a trial of the once daily versus the twice daily in the US, and this trial is completed accrual, and we anticipate some of the results that at the upcoming meetings in 2021, which may give us some additional insight into the benefit. The other thing that I would look at when I look at these trials, we really see that the survival improvement is continuing to increase over time for limited stage patients, probably due to superior staging, superior supportive care, superior radiation therapy techniques, And so people are living longer, which is important now. And we're really looking at the 5-year cure rate in this disease, because I think that's going to be the best metric of the long-term benefit of any of these strategies.